warm welcome to all of you in today's webinar on living with IBD and choosing the right treatment. The first in the Navigating Life with Inflammatory Bowel Disease series by ETHealthworld and Dr. Reddy's. Inflammatory bowel disease encompasses Crohn's disease and ulcerative colitis, which is a chronic condition that significantly impacts those living with IBD. Characterized by recurring inflammation of the gastrointestinal tract, IBD presents unique challenges to patients, caregivers, and clinical solutions. Our goal today is to bring clarity and practical solutions to these challenges while exploring treatment strategies from emerging therapies to personalized approaches, lifestyle adjustments, and more, all aimed to improve the quality of life for individuals living with IBD. I am thrilled to introduce our distinguished panel of experts, all leaders in the field of gastroenterology, starting with Dr. Sumit Bhatia, Senior Consultant Gastroenterology at Paras Hospital, Gurgaon, Dr. Praveen Sharma, Senior Consultant Gastroenterologist at Sir Gangaram Hospital, New Delhi, Dr. Ramesh Garg, Senior Consultant Gastroenterologist at Jaipur Golden Hospital, New Delhi, and Dr. Vibhu Vibhas Mittal, Senior Consultant Gastroenterologist at Max Hospital, Parparganj, New Delhi. Thank you for joining us today, everyone. So before we dive into the discussion, let's briefly understand the importance of the topic today. Effective management of IBD focuses on inducing and maintaining remission and minimizing the complications by ensuring a better quality of life for patients. With advancements in medicines and research, treatment now extends beyond medications to include dietary strategies, lifestyle modifications, and deeper understanding of individuals' variability. So let's begin the discussion to address as many aspects of IBD management as possible, starting with Dr. Sumit. So how does diet influence the symptoms of inflammatory bowel disease, and are there any specific foods known to exacerbate IBD symptoms?
Okay. Thank you, Rashmi, and thank you for the invite. Now this is the most burning question in the field of inflammatory bowel disease, or in today's world, as we call it, as gut health. So whether inflammatory bowel disease can be modulated, managed only by diet. So first we have to understand the basic. The basic is that inflammatory bowel disease actually develops because there is a dysbiosis. That means the gut flora changes into some form which is not conducive to our body's environment. And generally this dysbiosis is triggered by an environmental trigger. Now, exactly what that environmental trigger is, whether it is diet related, whether it is the current pollution, whether it is any other toxin or it is an infection, we still don't know. What we know is the result, because of a result of a dysbiosis and an environmental trigger in a person who has the genetic makeup or propensity to develop inflammatory bowel disease, there is an unchecked inflammation which happens inside the gut, and that leads on to these diseases. Now, since times immemorial, we have been trying to find out like what exactly are we eating or what should we not be eating to prevent this. So we still don't have that, that one, sure shot answer that don't do this and you will not develop IBD. But we do have some pointers in form of diet modulation. And some of them are that if we are not eating refined food, the less of refined food, less of processed food, less of saturated fats, and using less and less of additives. Specifically, research has shown that emulsifiers, additives, anti-caking agents, all these things which are added to our routine foodstuffs, which we are consuming out of, packaged food, lead on to inflammation inside the gut. Okay. So apart from these general, dietary advices, we still don't have that one thing which we ask patients to definitely avoid. Don't take this and you will not get IBD. But less of processed food, less of refined food, less of sugary foods remain the mainstay. And it has been seen that, as the world or our country's economy is progressing, we are moving towards more industrialization. The incidence of these diseases is increasing in our society. So less refined, more natural foods definitely helps.
So, going to Dr. Praveen, what role do food allergies and intolerances play in managing IBD? And can certain dietary choices help in reducing the frequency of flare-ups? Also, I wanted to know how can meal planning and preparation be optimized for those with IBD?
This is an interesting question because most of the patients who come to us, regardless of whether they have an IBD or they have other GI problem, they ask, okay, what should I eat? Whether should I eat chapati, should I eat rice, should I eat maybe curd or some milk and some milk products? So this is a very important question. We need to understand what does food allergies and intolerance means, because they are the words which are very, they are mimicking each other. When we say food allergies, it means food allergy means it is an immune mediated phenomena in which somebody who is unaware of whatever allergies he has. Suppose if he takes seafood, or he takes peanuts, or sometimes he takes some other things, and suddenly he develops a lot of rashes in the in the face, on the abdomen, on the other things. So these are the immune mediated reactions. When we say intolerance, means that it may be possible that he or person is able to take milk in the childhood, but as he grows older, then he is not able to take milk or maybe milk products because there is a deficiency of some enzymes. So it means the patient has developed non-immune mediated response, that he becomes intolerant to the diet he was able to take initially. So this is the difference between food allergies and intolerance, because many people ask, oh, I was able to take milk in the uh, earlier years of my life. Now I'm not able to take milk because it causes a lot of abdominal problems, discomfort, diarrhea. So what should I do? Similarly, if a patient who has got an IBD and suppose he has a intolerance to maybe milk now, and if he take milk, then he has more of bloating and diarrhea. So it is always advisable not to take milk, and he can take maybe other milk products like yogurt and other things which he is able to take it. So managing intolerance, so there are certain people who are, uh, they are not able to digest maybe wheat products, suppose. They are not able to digest maybe rajma. They are not able to digest some other foods. So it is always advisable to avoid those foods who triggers their problem. And it varies from person to person over a period of time also. So if the person feels that he is not able to tolerate or digest some particular food, it is always advisable to avoid that in the management of any GI problem vis-a-vis, we can say IBD. So I think one should, uh, it is a precision-based medicine that one should, try to avoid those foods by which the IBD causes flares up or it increases the symptoms.
Okay. And Dr. Ramesh, are there any emerging trends, especially in terms of the dietary trends or new research in the field of IBD management?
This is very interesting topic which you have taken up, because there's a lot of questions, as Praveen has emphasized, regarding the diet, whether it is the management of IBD or any other GI condition. So I think 100% of the patients do ask some specific dietary questions. As far as specifically to the IBD is concerned, there are two specific things I want to emphasize. Specific carbohydrate diet. We should avoid carbohydrates, complex specifically carbohydrates, and low FODMAP. This is a concept of, the FODMAP, the full form is the fermentable oligosaccharides, disaccharides, and polysaccharides, polyols. These are the specific subgroup of the food which can exacerbate the symptoms of the patient, as well as they are more induce the inflammation in the gut. So they are not only improving the symptoms, as well as the basic mechanism of the inflammation of the gut is also improved if we avoid specific type of food. I mean, one has to adhere to the low FODMAP diet. These charts are available online, and in the clinics, these low FODMAP diet charts are available, and we are, prescribing these charts to our patients specifically for the management of IBD, as well as specifically to the patients who are complaining of bloating, because these type of symptoms are definitely improved with them. As far as the new emerging trends is concerned, because high carbohydrate diet induces the inflammation, as well as they promote the unhealthy bacteria in our gut, which can lead to the increased symptoms as well as escalate the disease in the pathogenesis. So this is the another very important aspect of unwarranted side effect of the high carbohydrate, as most of the packed foods nowadays contains. Then the another very important concept is the prebiotics and probiotics. probiotics are the healthy foods, prebiotics are the food which helps in generating these probiotics. So these two type of interventions also, which as far as the new research is concerned, nowadays we are having the molecular testings, genetic testings, individualized testings of the specific microbiota of a patient, which can induce the symptoms, and by the specific addressing that microbiota, we can have the reduction in the inflammation, the symptoms of the patient, and the patient can go into the remission by the dietary modifications itself.
Okay. So, Dr. Vibhu, I want to ask, how can patients really ensure that they are getting adequate nutrition despite these dietary restrictions? And what are the key nutritional strategies for IBD management?
So patients of inflammatory bowel disease, be it ulcerative colitis or Crohn's disease, would have symptoms of pain, diarrhea, may have decreased appetite. So these three things themselves can result in poor intake as well as malabsorption of whatever they are eating. They might sometimes they might be eating adequately, but because of malabsorption also, they would end up with nutritional deficiencies. Uh, Micronutrient deficiencies is very common in these individuals. So they would have low iron, calcium, vitamins, predominantly vitamin B12 and vitamin D. Sometimes they can also have energy and protein malnutrition in patients who are in active flare. Even protein and energy malnutrition would be there. So it is very important for a physician or a nutritionist to take care of their daily needs. Find out if there is any deficiencies. Monitoring may be needed in terms of blood tests, checking their vitamin D levels, checking for their ferritin, hemoglobin levels, and vitamin B12 levels. Supplements of these minerals or vitamins should be liberally used in these patients, and sometimes fortified foods. So in a North Indian vegetarian diet, milk form an important source of calcium and protein. And as Dr. Praveen was pointing out, lactose intolerance, you end up decreasing this overall milk intake. So alternatives such as plant-based milks or fortified foods should be regularly supplemented in their diet.
Okay. Yes, coming back to you, Dr. Sumit, what role does supplementation play in the diet of an IBD patient, and can probiotics and prebiotics be beneficial for IBD patients? If so, how?
Okay. So as Dr. Vibhu was pointing out, so there are three aspects to your question. One is the supplementation of micronutrients. So research has clearly shown that vitamin D deficiency can exacerbate gut inflammation. So, supplementing vitamin D and maintaining their levels slightly above the therapeutic range has definitely shown to be helpful in our patients. Secondly, supplementation of calcium, especially because some of these patients will be on steroid therapies again and again for control of their inflammation. So osteoporosis, the bones getting weak is very, very common. So calcium supplementation definitely helps. Most of these patients, because of their constant inflammation, land up in a state of iron deficiency. So iron supplementation, either oral or through parenteral, that is by IV means, is definitely on the cards, and these micronutrients be regularly supplemented. Another micronutrient which we very usually supplement is vitamin B12 and folic acid supplements. So these are for the micronutrients. These are the common ones which we generally supplement. As far as prebiotics and probiotics are concerned, so prebiotics are the foodstuffs which will improve the growth of the gut flora, the probiotics. Okay. So fiber is an important source. So, many of us tend to restrict fiber in our, IBD patients, and there is no definite scientific evidence to support that. Except for, very, very few significant, very few patients who have, stricturing disease, wherein it is medically indicated to avoid insoluble fiber. Soluble fiber should be supplemented. So, one of the most important aspects of prebiotics is fiber supplementation, having more natural and less processed foods. Probiotics is a very, very controversial topic. I think we'll be discussing it through the discussion now once you have started that. But probiotics, the jury is still divided. So probiotics, except in certain situations like pouchitis. So now pouchitis is a very, very specific subset of IBD patients who have undergone, the colon removal surgery, and there is a ileal pouch which has been made. Now, in pouchitis, definitely probiotics have shown to be beneficial in addition to antibiotics. Now, in very, very limited number of studies in ulcerative colitis, it has been shown that, probiotics can be useful, and that too very specific strains of probiotics, not the regular over-the-counter probiotics, which we generally get. Now, probiotics, to the best of scientific evidence which is available today, are only adjunctive treatments. And especially in Crohn's disease, we have not been able to definitely say that, probiotics are useful. So as an add-on supplement, yes, maybe. But if you ask me whether definitely we need probiotics for the treatment, except for the situations which I mentioned, no, I don't think that, probiotics are scientifically indicated to be given to every patient. We only use them at best in situations like an antibiotic-associated diarrhea, because most of these patients will get antibiotics from their physicians or their local practitioners to for any kind of a flare-up. And in those situations, we do end up using. Otherwise, as only an add-on treatment.
Okay. So, Dr. Praveen, why is it important to manage hydration in IBD symptoms?
Managing hydration is important for any disease. Anybody who is ill should have adequate hydration. Patient we say about the IBD patient, they generally have two phases. One phase is they are stable, that they are eating normally, they are taking normal diet, drinks, and other things. But once they are symptomatic, when we say symptomatic, it means they have increased diarrhea, they have, their hydration becomes low. So it is always better to maintain a good hydration in their symptomatic phase. Make them to drink as much as they can, because there is no strict formula that how much liquid or how much water they should take. If they are feeling thirsty, they should take adequate amount of liquids. The ideal goal is they should pass a normal urine. Suppose they were passing about 1 liter of urine prior to the symptomatic phase, then they should take as much of amount of fluid in the form of either water, coconut water, or whatever the amount of liquid that, to maintain a normal hydration and normal urine output. So the single important thing is that if they are passing adequate urine, it means that they are hydrated. If they are passing less urine, it means they are dehydrated and they should take water and other things. If they're not able to maintain that, I think it's better to contact a doctor.
Okay, so the next question is on how a registered dietitian and nutritionist can assist in the management of IBD. Dr. Ramesh, this is for you.
Yeah, thank you for the question. Nowadays we do have specific, the dietitians who are specifically meant to manage, only GI issues. Okay, as you have seen in the practices also, as you have seen in that there are few dietitians who practices only weight loss management, diabetic management. Similarly, we have the specific dietitians who are well versed with the GI issues, whether it is irritable bowel syndrome or the inflammatory bowel disease, which is the topic of today. So a registered dietitian or a specific dietitian can be very helpful in creating a personalized nutritional plan for a patient, the more specifically to address the specific symptoms, the patient choice of the food, because in our we Indian people are pretty choosy in our foods, so each one has their own choices and everything. So they make up a good the customized food which can alleviate your symptoms as well as do not exacerbate the symptoms. So that is the main idea, and they definitely helps in the nutritional supplementation guidance, as we have already discussed that many of these patients are deficient in iron, vitamin D, vitamin B12. So there are specific dietary supplements which can increase these dietary deficiency. Similarly, many of these patients are already malnutrited. They are at the protein loss, they are having sarcopenia too. So that way also a specific registered dietitian can help in managing that. And of course, the monitoring and the evaluation of all these patients, the nutritional status plays a very important role in the all chronic disease. As you know, IBD is a chronic disease. Probably it is a lifelong disease. So the continuous monitoring of the patients in the nutritional status, whether the patient is not going to be the malnutrition, deficiencies, as well as the symptoms are adequately controlled, like we have already discussed, that the bloating is there, then the low FODMAP diet type of thing, which can be instituted to control and improve the symptoms. If the patients who are having the Crohn's disease, they have the structuring disease, then the low fiber diet is required in these patients. Sometimes the elemental type of diet is required. So a registered, specific dietitian who is versed with the IBD can manage these patients in a better manner. So this is the, this strategy is definitely helpful. Thank you.
Thank you, Dr. Ramesh. Coming back to you, Dr. Vibhu, can you explain me how yoga might affect gut health and the digestive system? And how often should IBD patients practice yoga to see beneficial effects?
So yoga or other complementary exercises should be done by everybody to maintain their health. In an IBD patient, in a sick IBD patient who has pain or diarrhea, etc., they should refrain from using yoga as a treatment modality. But this can be contributory in maintaining the overall general health also of an IBD patient. Yoga by its virtue of reducing stress will help you in stress mitigation. It has been shown to possibly reduce cortisol, and stress is a significant factor which affects the symptoms in IBD. Whether it results in relapse or not is controversial, but definitely it would contribute to the symptoms in these patients. So the relaxation techniques of yoga, deep breathing, meditation, mindful movements are always welcome in these patients, as they're welcome in other individuals as well. There's been some talk of specific yoga poses which might help these IBD patients. The literature on this may not be very confirmatory, but then yes, there is no harm in doing poses where they might be focused on gentle restorative poses which promote relaxation and may support digestive systems. It might improve the gut blood flow and the gentle abdominal organs, aiding in digestion and reducing the symptoms like bloating and constipation. The frequency, ideally, any exercise which includes yoga as well should be 3 to 5 times per week at least. Something is always better than nothing, so even short sessions can also be effective in reducing stress and supporting gut health. But it is important not to overdo things. Listen to your body, especially a patient who has a chronic disease like IBD should avoid poses that may cause discomfort or strain. Modify poses as per the yoga instructor in case of a problem. And we should understand, the individual should understand that it is just a part of the comprehensive treatment plan. The problem starts when you start treating the IBD with yoga. So yes, it may be part of that treatment plan where medical treatment, diet and nutrition, and after that mental health and yoga might help in overall improving the overall well-being of the patient.
Okay. So, Dr. Sumit, how do doctor-patient meets and patient education empower them for effective IBD management?
Okay, now this is the most, I think, the neglected but very, very important aspect of the treatment. So traditionally, inflammatory bowel disease was never considered, to be an Indian disease. So for decades together, this disease was supposed to be present only in the Western countries, in the more developed nations. And it was always believed that, in India, what we have is not inflammatory bowel, but what we have is an infective bowel. So we have more infections here, not inflammation. And that was a traditional teaching. But by last 3 decades, what we have seen is the numbers have been rising so rapidly in our country. And now, because of more awareness amongst the healthcare workers and patients both, now we are diagnosing many young patients, many elderly individuals with IBD in our country. And possibly, I think we are the second largest population of inflammatory bowel disease patients, only next to the United States in this country. Now, this also poses a lot of challenges. The treatment is not simple of IBD. It's a lifelong disease. It's a chronic disease. It has got its, periods of flares. So to manage and to circumvent all these problems, what we definitely need is a patient-doctor relationship. Unless and until, that patient-doctor connect is there in this debilitating disease, the treatment outcomes are not going to be good. One, because we'll not be able to optimize the treatment. Second, the patient will not be able to accept any kind of treatments. Now, with the advent of newer therapies which are available for treating IBD, such as biologics, it is very, very important that the patients are first, they are aware of what they are dealing with, what is Crohn's, what is ulcerative colitis. Second, they should be, an equal partners while deciding any therapeutic plan, very treatment plan for them. Most of the medications which we use them in combinations. Some of them are really expensive. Some of them have significant, health concerns, and they are also very, very efficacious. So, a balance. There is no one treatment for every patient. So each patient, depending on their age, safety profile, disease activity, severity, we have to tailor-made the treatment for that particular patient, and we may have to go on changing the therapies depending on what the clinical response is. So patient education awareness is extremely, extremely important. Now, part of it, yes, comes from our clinic when they come to us, but again, there have been now support groups, the patient empowerment groups, which have been formed to raise the general population's awareness regarding how to deal with disease. I'm very sure that if you just, mention IBD in general population, most of the people may not be aware what is ulcerative colitis, what is Crohn's disease. So these are relatively new for us because we have seen more patients coming in only last 2 decades. Now, there have been many, many support groups like Crohn's and colitis foundations across globe. So Crohn's and colitis foundations are there in different countries, wherein different patients and healthcare physicians come together to educate patients and healthcare physicians regarding these diseases. We also have something like I'm a part of an alliance called the South Asian IBD Alliance and IBD Desi support group, which is, which are patient-centric groups, which have doctors inside them, but they are run by patients for the patients to get the right kind of information that how you can, get the right treatment, what are do's and don'ts, what are the myths surrounding this disease, and especially, to avoid and dispel the stigma. There is a big, big stigma attached to any kind of chronic disease, especially if it is related to bowel and gut. So that is very important. So patient-doctor meeting, I think is the first step. If that meeting goes wrong, everything goes down the drain.
So that very important points given there, sir. So my next question will focus on how do adjunct medications actually complement primary treatments for IBD? And this question is for Dr. Praveen.
Whenever a patient of IBD comes to us, he may be having an acute symptoms or he may be a stable patient. So when we use medically, there are certain medications which are used to induce remission. When we say to induce remission means the patient has got problems and we give some medication so that his problems settle down rapidly. When the problems settle down, then we give some medications which are used to maintain that remission. So they are known as maintaining drugs. So they are very important because, if you give medications which are used to induce remission for a prolonged period of time, they may have their own complications. So you need to tackle down according to the patient needs and in discussion with the patient that there are certain medication you need to follow for a certain period of time. Here comes the patient-doctor relationship, as Dr. Sumit says. So this interaction is very important. So we have some medications we have steroids, we have biological therapies which are used to induce remission. And once the patient has got symptoms which are relieved, then we give certain medications like mesalamine and sometimes a low dose of steroids and even biologicals to maintain them in a maintenance form. So these drugs are used mainly for the induction and for the treatment part. So, once we say there are certain medication, this medication has got its own side effects. So you need to monitor these medications in between that whether the patient is getting some side effects of it, then you need to change according to the patient to patient profile. It may be possible that the patient may not respond to your first line of treatment. Then you need to add on certain medications. So, there are the group of medications which are used in patient of IBD and that varies from person to person and over the period of time from the same patient to the patient, you may need to change that medications. So I think treatment is the main part in which you need to treat this such type of patients.
Okay. So the second part of this question is also, what role do anti-diarrheal agents play in the management of IBD, and which anti-diarrheal medications are most commonly prescribed for IBD patients? This is for
These are very
you.
important question because, suppose sometimes a patient came to us with an acute history of diarrhea. Maybe they are having problem for the, I'm not talking about the IBD. Suppose any patient who come to my clinic with a history of loose stools, he has taken food some from outside, he got fever, he got loose motions, and he wants to get rid of his problems rapidly. So sometimes we give antidiarrheals. Antidiarrheals are the drugs which try to reduce the motility of the intestine so that the patient feel better, and the hydration also becomes slightly better because he's not going to the passing stool every time. But in a patient who has got IBD, use of antidiarrheal drug is a very tricky thing, because any patient who has got an acute flare and you give antidiarrheal drugs in that phase because you want to relieve his symptoms, then sometimes it can complicate the problem because the inflammation is still there and you want to reduce the volume of the stool. Then there are certain complications. The infection may precipitate, his abdomen will become more distended, and sometimes the stage can come to the stage that even the intestine can perforate. So use of antidiarrheals in a patient of IBD is very crucial, and it varies from person to person, the doctor to doctor, when he wants to use it. So there are certain drugs which are used. The commonest one is the loperamide. It try to reduce the frequency of the stools by reducing the intestinal motility. There are certain other drugs like difenoxalate, commonly named in the name of Lometil. But I will, no, it's my suggestion that if a patient of IBD, use antidiarrheals to the minimum, because if you give other medications, his diarrhea will, subside more compared to giving them just an antidiarrheal drugs. And you should, tell your patient that don't use antidiarrheals unless you have contacted your local doctor in patient of IBD.
Okay. Dr. Ramesh, my next question is, how do pain relievers help manage the symptom of IBD? Are there any pain relievers that should be avoided by IBD patients? And what are the potential risks of using pain relievers? Uh, Also, how can these IBD patients safely incorporate pain relievers into their treatment plan?
I think this is a very important question because we have to address the symptoms of the patients too, because that is the immediate thing which our patient expect from us as a doctor. And the pain is a very significant part of the disease, specifically more so in the Crohn's disease. In ulcerative colitis, we don't have too much of pain. However, in Crohn's disease of the patients, if they have structuring disease, then the pain can be pretty significant. I will answer the most important thing first, that as you have asked the potential side effects, because the common painkillers which have been used for the body pains like neuromuscular pain, a group of drugs called non-steroidal anti-inflammatory drugs like aspirin, combiflam, dispirin, as you have heard, nimesulide, they should be totally avoided in the management of IBD for the pain relief, because not only they can induce the complications, like they can start bleeding, they can perforate the bowel, they can increase the inflammation, and they can be detrimental and can be life-threatening in these patients. So the safe group of pain reliever in these patients are antispasmodic, anticholinergic drugs like hyoscine and dicyclomine, or the simple paracetamol in the doses of pain relief. That is approximately 3 to 5 grams per day. So this should be kept in the mind. The another pain group, pain relieving medications like the opioids. Again, there is a problem with that, because if you use them continuously, because as we have already discussed that this is a chronic disease, most of the patients have fluctuating symptoms. The symptoms come, goes, and again the symptoms are there. The drug abuse, or the many of these patients may get the opioid dependence. So they itself adds to another disease if you use these opioids for the pain relief. So this is a very, we have to act in the balance to, control the symptoms and using the drugs. So safe medications, I have told you, I'm the anticholinergics and the paracetamol type of group. And as well as we should educate and aware all the patients that, of course, pain relief is related to the symptoms control and the control the disease itself. So the other disease which are acting directly on the disease. If we control them, the pain will automatically goes away. So this is how we have to educate our patients too, because they should not be much stressed on the pain itself only, because that pain is the one of the symptom. It is not the disease. Thank you.
Okay. So, Dr. Vibhu, how can iron supplementation help manage IBD-related anemia? And what are the potential side effects of iron supplements in these patients? Also, how should iron levels be monitored and managed in the IBD patients, if you could highlight?
So as we have already discussed, iron deficiency is very common in patients of IBD, be it Crohn's or ulcerative colitis, because of poor intake, chronic blood loss, either overt or occult, as well as malabsorption. Um, Low iron levels results in low hemoglobin, and low hemoglobin results in persistent symptoms of fatigue, breathlessness, not feeling well. If you can take care of the iron levels, hemoglobin would go up, and a sense of well-being would also come up, apart from reducing symptoms of fatigue, weakness, shortness of breath, etc. So, managing iron in IBD is very important. Has been shown beyond doubt that it is of help and should be done aggressively these days. Uh, Now, to manage iron, we have three things which can be done. One is looking at the nutrition. We have already talked about it. Second is supplementing iron with oral or parenteral forms. Now, oral is the standard usual form, but the problem with oral form is that the oral tolerability of iron preparations available may be poor in these patients. It is poor in general population as well, but the oral tablets of iron may result in symptoms of nausea, constipation, diarrhea, abdominal pain, and these patients already are suffering from these symptoms most of the time. So these patients may not sometime or frequently tolerate oral preparations. IV preparations or parenteral preparations are now very safe, and we call that total dose infusion. So iron can be infused with a simple IV injection over a period of 30 minutes in one or two separate sittings, is safe when done properly in a clinical establishment, and rapidly take care of iron deficiency. In anybody who has significant anemia, iron deficiency, or even a non-significant anemia, but poor tolerability to oral drugs, iron infusions, parenteral iron may be considered.
Okay. So, my next question is for Dr. Sumeet, furthering on the prebiotics discussion that we did. How could you elaborate on how can probiotics help in reducing IBD symptoms and improving the gut health? How should probiotics be incorporated in the IBD patient's overall treatment plan, and are there any risks associated with this use?
So again, as I pointed out, probiotics usage, there is no significant scientific evidence to, indiscriminately use probiotics in all IBD patients, except, patients who have an ileal anal pouch. This is after a major resection surgery for ulcerative colitis patients. Generally, we make that ileal anal pouch. So who have a J pouch and they have the inflammation of the pouch, antibiotics have definitely shown to have benefit, as well as probiotics have been shown to have definite benefit. Now, in ulcerative colitis patients, in extremely limited studies, there are certain strains of bacteria, especially like E. coli and Nissel strains, which have been shown that they can be used in maintenance of remission in mild to moderate ulcerative colitis. Similarly, there are certain preparations of probiotics which have been shown to be beneficial in ulcerative colitis patients. Till date, there is no sound scientific evidence to say that probiotics are useful and should be used for indiscriminately all patients of Crohn's disease. Now, having said that, we still use probiotics as an add-on therapy to our standard medical care in some of our patients, especially who have antibiotic associated diarrhea, who have infective diarrheas which have recovered, in patients who have irritable bowel syndrome, like the diarrhea is not settling down but inflammation is under control. So we do use for symptomatic relief probiotics. The problem with probiotics which are commercially and over the counter which are available is that, you have you don't have a control. Most of the, government authorities cannot control that what is going into those packagings. So probiotics work and specific bacterial strains work differently. So strain specificity of a probiotic is very important, which is at times missing from the commercial preparations. So what strains are we using, in what dosage, what colony counts we are using, and what is the source of obtaining, those probiotics, are the, major questions before we prescribe these for, all our patients. There have been certain strains which have been shown to have added benefit in patients of IBD, especially some strains of bacteria like lactobacillus, some bacteria like Saccharomyces boulardii, but those are far and few in between. So at best, except for specific situation, I would say that, probiotics are not something which should be used for, as a treatment modality for. They can be used as an add-on drug, and that too in specific situations. Okay, so it's just a nutraceutical supplement, nothing else as far as IBD treatment is concerned. Okay, there is an upcoming role of fecal microbiota transplant in inflammatory bowel disease, wherein, the fecal, slush from a normal, so-called normal patient with a normal bacterial flora, we transplant into, another patient. But the concept is the same, that, you change the gut flora of an, inflamed gut to a normal gut, and the inflammation will disappear. But what strains exactly are we talking about? We still are, many steps away from that concept as of now. So just a pill of probiotic, I don't think is going to add much of a difference.
Okay. Dr. Praveen, the next question is, can you discuss any novel treatment approaches currently under investigation for IBD, and how is research addressing the genetic factors involved in the disease?
I think Dr. Sumit has slightly mentioned about one of the new targets of management of IBD, that is the change in the gut microbiota, which can be done either by supplementing maybe pre or probiotics, and sometimes the fecal microbiota transplant, that is known as the FMT. But still it is in the preliminary stage. We do not have much evidence in favor of Crohn's disease. We have some evidence that probably it is helpful in ulcerative colitis patient. Then we have certain drugs which have now come up in the injectable form, that they need to be given every 3 to 4 weeks interval. And they are targeting on certain part of our immune system. And we have inhibitors for integrins, we have inhibitors for IL-12. So there are a number of molecules, small molecules, which come in the immunological pathway for the inflammation. So we have certain targets on that. These are known as the biological therapies, but most of these are injectable things. And they are costly also and cannot be used by majority of Indian people. So come certain newer therapies, which are known as the small molecules. What are small molecules? These are the standard pill-like drugs, which are to be taken on daily basis, and they can be stored at home also without any refrigeration, and they are cheap also. So these are known as small molecules, so which is good for the Indian people. They have primarily come for the ulcerative colitis patient, like we have tofacitinib, but there are certain small molecules which are known as JAK inhibitors, which have also come up for the Crohn's disease and as well as for the ulcerative colitis. So I think the future of the therapies of IBD is the small molecules. Probably the upcoming drug, which is known as opatostinib, probably will come in the next few months. That the single pill will cover the treatment of IBD, whether this patient has an ulcerative colitis or patient has a Crohn's disease. So this is one of the latest landmark in the treatment of IBD. Then we have certain more targeted therapies, that we develop certain types of T receptor T cells, which are taken out from the patient blood. We change the T cell surface so that they probably attack certain antigens which are not good for our immune system, which is known as the CAR therapy, which is known as CAR T cell stem therapy. So these are the newer drugs which are upcoming for the treatment of IBD. Probably the small molecule is the drug which will probably be the key role in the management of IBD.
Okay. And Dr. Ramesh, if you could highlight what role do microbiome studies play in the current IBD research, and how are advancements in immunotherapy impacting the treatment of IBD?
Yeah, again, this is a good question, because as we have discussed throughout, this debate is this throughout discussion has been going on for the probiotics and the dysbiosis. I mean, so there is a different, altered bacterial genome is present in these IBD patients. So there is a lot of research which is going on regarding the disease mechanism. Basically, what we have to understand, it is the altered host immune system which is responding adversely to our own microbiomes. So your own body is against your intestinal bowel microbes. So that is the main pathogenetic mechanism of IBD, inflammatory bowel disease, ulcerative colitis, and Crohn's disease. So many newer things are being developed, like identifying the specific microbial genome, which can identify at what time the disease onset. It can trigger the flare of the disease, at what point of time, which organisms are there, what is the microbiota at that time, what is the microbiota when the patient achieved the remission, what are the microbiota specifically when the patient is not responding to the specific drug. So a terminology has been, the microbial signature of that specific patient identifies that whether the patient is going to respond to the specific drug or not. So these are the newer things which are under the research. And there is a lot of work which is being done, as Dr. Sumit Bhatia has discussed, the FMT, that is the fecal microbiota transplantation, or the intestinal microbial transplantation is, even we have the randomized control trial in the ulcerative colitis, but not in the Crohn's disease, and the results in the 2 of the 3 trials have been favorable. So this may become a future therapy for our IBD patients who are not responding to the conventional treatment. So this is again a new, exciting era of whole, the current research in the IBD regarding microbiomes. The immunotherapies, again, the partly been discussed by the Dr. Parveen, that a lot of anti-TNF agents. TNF is the main pathogenic marker for the activity of the disease. This is a cytokine which is exaggerated in these IBD patients. So various drugs like infliximab, adalimumab are available. The other drugs Dr. Praveen has already discussed, like small molecule drugs like tofacitinib, JAK kinase inhibitors, they may also play as a immunotherapy in these roles. Newer other drugs like IL-12 integrin inhibitors, these are under the way, which have the better control of the symptoms and the disease remissions, the patients who are refractory and not responding to the conventional treatment. So there is, again, because as we have the basic premise is that this is the dysbiosis and the altered immune status system between the microbes and the immune host. So a lot of work is being done to address these issues. Thank you.
Okay, so come to the last question of the session today, and this is for Dr. Vibhu. What role will personalized nutrition play in the future management of IBD? How can future research improve the early detection and prevention of IBD? And the concluding part is, what collaboration between academic institutions and healthcare providers and industry can play a crucial role in advancing the IBD research?
So this question has actually 3 parts. Let us first talk about the first part, which is the personalized nutrition in future management. And to some extent, personalized nutrition in the present scenario would be a customized supplementation, which we already do about. We offer nutritional deficiencies. We look for nutritional deficiencies and treat them based on that, then monitor and adjust diets based on the nutritional deficiencies. This is what is presently, which is doable, or what we do. Next is tailoring the diet to the individual needs. The form a precision diet plan. Look at the unique genetic microbiome and the metabolic profile of that individual, may or may not be IBD, and then help identify specific foods that may exacerbate or alleviate IBD symptoms for each patient. When will that be possible? We don't know, but yes, that is something which is achievable with the kind of research which is going on in the genetics and the microbiome of individuals. Nutrigenomics is a term where we talk about the genetic information to understand how a patient's diet might interact with their genes and result in development of diets that can minimize inflammation to that particular individual. Similarly, diet also has an impact on the microbiome, and all the 3 previous speakers, Dr. Sumit, Dr. Ramesh, or Dr. Praveen, have already talked about that we understand that microbiome has an impact on IBD, but unfortunately, presently, we do not have power to properly modulate this microbiome to benefit these patients. Once we understand that, probably dietary impact on microbiome may also have an impact on the management of these patients. So this is the first part of your precision diet plan or to managing these patients. Next is, yes, improving early detection and prevention of IBD through future research. IBD has some component of genes involved. There are, as Dr. Sumit pointed out in his first question, in somebody who is likely to develop IBD, environmental triggers may result in IBD. So there are multiple genes which are known to increase the predisposition for development of IBDs, and research can focus on identifying these genetic markers which might indicate higher risk of IBD. And early identification of these at-risk individuals can lead to preventive strategies and close monitoring. Moreover, we also need to have non-invasive biomarkers that can detect early signs of IBD and flares, so that the individuals can be treated before developing serious diseases. Environmental lifestyle factors may also contribute to these identifying these triggers. Such as diet, stress, antibiotic use. We know that these are problems these are triggers which result in relapse in IBD patients. But our understanding of these needs to be further nuanced, so that further preventive measures can be planned. And microbiome research, again, Dr. Ramesh was talking about it. Early microbiome change can be used prophylactically. Probiotics, these are things for future, once we start understanding how modulating microbiome may help us. For any chronic disease, be it cancer, be it IBD, be it diabetes, something where ongoing research and interdisciplinary research on top of that, like collaboration among different disciplines such as genetics, microbiology, immunology, pharmacology, nutrition, gastroenterology, is paramount to improve our understanding of this disease, to find out newer medications newer targets which might help treat the disease, cure the disease even. So yes, a multi-disciplinary, interdisciplinary research between academic institutions, and then once the research comes in, healthcare providers need to translate that research to the community. Like Dr. Praveen was talking about small molecules. Once they come in, the collaborations can help ensure that new treatments and preventive strategies are then effectively implemented and monitored. Dr. Sumit was talking about India being the second largest number of IBD patients in the world now, but unfortunately, we need to maintain better patient data, and then these samples sometimes may be used for research purposes in biobanks or facilitating large-scale studies. So this collaboration is important. For industry also, collaboration with industries to accelerate the development and testing of new drugs. Fortunately, for last decade or so, there has been much advancement in this area. Improvement in the new diagnostics to advanced tools for early detection monitoring is needed, and cannot be said that all this requires funds, and funding and policy support by the industry or by the government and public awareness campaign would go a long way in helping us to better understand this disease, for us to maybe after a few years saying that we understand this in a much better way, and these are a better therapeutic targets for this. Thank you.
Thank you, Dr. Brudu. And that brings us to the end of this session. Expert panel, for your valuable insights and practical advice. I am sure our audience has gained a deeper understanding of IBD management and hope that the advancements in treatment bring. So thank you to ETHealthworld and Dr. Reddy's as well for organizing this important series. And finally, a big thanks to all the audience for joining us today. Let's continue to advocate for awareness, education, and support for those living with IBD. Thank you, everyone.